Hello, everyone. Thank you for joining us for tonight's National Primary Care Week webinar. My name is Jenna Fox, and I'm the Primary Care Coordinator for the American Medical Student Association this year. So tonight we have Heather Alva speaking to us. She's a third-year medical student at Oregon Health and Science University in Portland. And in 2010, she graduated from Stanford, where she studied healthcare reform and creative writing. She's going to talk to us about a variety of things, and it should be a great talk. So take it away, Heather.
Thanks, Jenna, and thank you to everyone who's joining us today in this call. I'm going to start with sort of a disclaimer, which is simply that I am going to be talking about something that diverges somewhat from the other webinars this week by taking the conversation somewhere extremely personal. And sort of the inherent awkwardness of doing this is that I will be telling my patient's story. If anyone has any exposure to the American Resident Project, which is what linked me to this webinar, you probably know that I am type 1 diabetic for 16 years now, longer than not, which will be predominantly the emphasis of this talk. And, oops. Why is it not progressing? Let's try this. So roadmap, like I said, just so everyone knows, I'm hailing from Portland, and this is Mount Hood. The weather is really nice out today, and so that means we get to say the mountain is out. And I did just check, and the mountain is out. Today I'm going to talk about three things. I'm going to start by going over in a lot of detail my own patient experience. And then I'm going to kind of transition into, as a student, what my experience has been with underserved populations. And then I'm kind of going to leave everyone with some take-home points. And it's going to focus on how one has informed the other, and maybe how my patient experience has informed my experience of working with underserved populations, and how it's really enriched it and made it a very rewarding experience for me. So this is me, circa 1998. It's a Halloween picture because we are about to celebrate my favorite holiday, and this was my favorite Halloween costume of all time, homemade pink Power Ranger. And I do like to always begin a story about a patient experience with a face, and since no one can see my face right now, we'll just start with pre-diabetic 10-year-old Heather. So this is my cleverly titled slide, History of Present Illness. And I'm going to go through some of the more salient points of my illness, focusing on diagnosis, because for a lot of reasons, and for a lot of people, that's a really powerful point in having a chronic illness. The day-to-day sort of blurs. So we have to go back about 16 years to December 26, 1998, and you can tell that's the day after Christmas. So 2 weeks before that, if there's anyone who is a physician or who is a medical student or pre-med student who has seen a patient, a pediatric patient diagnosed with diabetes, this is going to be a pretty classic story. But I started with flu-like symptoms. So when my mom took me in to see the doctor, they correctly said it was the flu and sent me home, fluids, rest. But after about 2 weeks of losing weight, I had gone from 75 pounds to 55 pounds, which is substantial. My eyes were bugging out of my face, and I must have looked like a shriveled bean of a human. I didn't have any liquid left in my body. I was drinking water all the time. I was constantly thirsty. I, at that point, was not hungry. I had to pee constantly, and one of the things I actually remember the most during this time was every night I would go to bed and I would wake up maybe in 2-hour intervals because I would have to pee, and then I would be so ravenous for water that I would drink from the faucet, and I would try not to because I know that would be perpetuating the cycle of my having to wake up and pee again, but I was just so hungry for water that I would chug from the faucet, not even go to the kitchen, just chug from the faucet until I couldn't drink anymore, go back to bed and do it again. And because this was happening at night, my parents really didn't know. So my parents could see, obviously, that I was losing a lot of weight and that I was really sick. But this sort of classic, like, peeing all the time, drinking lots of fluid was really something that I think everyone looked back with 2020 hindsight and was like, oh, that was so classic, why didn't we catch it? But for me, who was only 10 years old at the time, my experience with my body and really with the world was largely observant. So I sort of chalked this up as new normal and just kind of tried to adapt to it. I didn't actually even really question it. It probably had a lot to do with the fact that I was sick, extremely sick, and not thinking totally. But I think in general that can be true. Sort of people habituate to things fairly quickly, especially kids. So the day after Christmas, I ended up chugging enough water that I vomited at least my stomach's worth of fluid. My parents took me to urgent care, and I was so dehydrated that I'm sure they handed me the urine specimen cup more as a formality. But I filled the cup, and they were like, this girl has diabetes. Send her to the emergency room. They tried to check my blood sugar in the urgent care, but something that's kind of funny about monitors is a lot of them don't go past 500. So if you have a blood sugar higher than 500, it just says high, which is sort of obnoxious, and it doesn't even spell it right. It says HI. So they sent me to the emergency room where they have a bigger glucometer and probably a bigger needle. I think I would have described it as being stuck with a push pin, partially just because the whole thing felt very dramatic. But my blood sugar was 981, and for those of you who don't know, normal blood sugar range for somebody who doesn't have diabetes is probably about 70 to 120. So 126 fasting is diagnostic of diabetes, and my blood sugar was 981. So pretty impressive that I was even walking around, but it landed me a 3-day stay in the ICU, and there were 3 things about that stay that I remembered the most. One was, this was back before DVDs, so we only had videotapes, which now makes me sound super vintage, but there was only this videotape of Sandra Bullock in the net, and I can't remember, but I'm pretty sure that movie is PG-13, so I don't know why it was in the peds, and I also don't know why I was allowed to watch it, but I think I watched it about 5 times. And I was introduced to diet sodas, and anyone who's ever had diet sodas in a West Coast hospital, it's Diet Shasta sodas, and they are disgusting. So I have strong ties of Diet Shasta colas and Sandra Bullock to my early days of illness. And the third thing that I remember is learning how to give myself shots, which for somebody who was as squeamish as I was, I think I must have been 2 standard deviations above normal in terms of squeamishness about needles, and venipuncture especially, probably still, to be honest. So when the nurse came in and sat down on my bed, and in retrospect, I think I had been sort of given information about what my life was going to look like at an appropriate pace and from appropriate people, mostly my mom. But a nurse came in with some oranges and basically was like, okay, we're going to practice giving shots. And I had this image in my head that it was going to entail like basically injecting my veins for the rest of my life as if I were a heroin addict, and I would have pock marks and the whole thing. And I firmly believe this at 10 years old. So as soon as I found out that an injection with insulin is just straight into your tissue, I think from then on out, I really loved having diabetes. Stretch to say that I enjoyed the shots, but I didn't mind them. And I sort of loved that everyone else was disgusted by them. And I loved that I was allowed to have food when other people weren't allowed to have food, and that I had some kind of authority and knowledge about the human body that even adults didn't have. And in a lot of ways, I mean, I say it was a power trip, but I think an outside observer would say I was empowered as a patient. But I really enjoyed it as a kid. I thought it was great. So the other thing I want to emphasize, and I don't know if this is something that's really spoken about in medical education, but the actual feeling of having high blood sugar and the actual feeling of having low blood sugar can be very dramatic. And I think this gets understated because it happens so often, But to just kind of tap into the inner landscape of my brain, the world falls into two categories: things that make my blood sugar go up and things that make my blood sugar go down. And pretty much at any given moment, I'm weighing what goes into these two buckets. I'm not going to go super into depth because I don't want to give a whole physiologic lecture on diabetes, but you can kind of tell that things that lower my blood sugar are insulin, exercise. Things that raise my blood sugar, carbohydrate, and pretty much anything that stresses me out. And you can tell there are a few things on both sides. It's not a mistake. It's only a testament to how variable things can be and how complicated things can be. And I would also like you to note that a lot of these things are unquantifiable. So it's not as simple as testing your blood sugar, insulin in, blood sugar out. It's never that simple. On any given day, there's at least 1 million things that go into one blood sugar. So the feeling of high blood sugar, as probably a lot of you have heard, it's sort of just like having the flu, except it's having the flu any given day. I'm sorry, that's my dog. Having the flu any given day at any given time. It can worsen illness, which is frustrating. It can make you boggy. If you imagine that high blood sugar can be induced by stress, and then you imagine sitting down to take step 1, and then you imagine sitting down to take step 1 with a blood sugar of 200, it really poses a specific challenge, especially in an academic setting where stress is a huge component of elements of performance. So that's been a big thing for me. And I've taken a lot of sick days, and a lot of times it's been challenging to make people understand what it's like to have high blood sugar, how complicated it is, and sometimes how incapacitating it can be. The low blood sugar, I think, is a more interesting phenomenon. It's most known for making somebody with diabetes shake. And if you've ever been in a near-miss car accident, or if you've ever maybe gotten away from the police, did something you shouldn't have done, probably shouldn't have gotten away with it, and you leave the scene shaking, anything that pours adrenaline into your system that causes your hands to shake, it's sort of that basic feeling, except it magnifies over time. And you can end up feeling terrified, sort of like a panic attack. You essentially feel as if you are dying because you are actively dying. If you continue on the trajectory of blood sugar dropping, that's exactly where you're headed. So I'm going to kind of come back to why I'm really emphasizing this when I transition into talking about the patients I'm working with, but I just want you guys to keep that in mind. So finally, I just wanted to mention that I have an insulin pump, which I didn't get until I was 18, and I probably needed it a lot sooner. And it wasn't for lack of trying on the part of my pediatric endocrinologist. It was more, and this is something I didn't have the insight to understand when I was 16, but kind of reflecting back, the real issue was that I didn't want something hanging off my body, and largely diabetes is not an illness where you have any physical manifestations. When I meet people on the street, I'm sure I tell them probably one of the first things they know about me is I'm diabetic, but you can't tell by looking at me that I'm in any way ill or sick or that there's something not working in my body. And when you're 14, 16, that's a huge challenge. And I think that's an issue that is probably more pronounced among pediatric populations, but it's definitely something that I think is worth mentioning, that sometimes there are motives that even the patients themselves cannot articulate. And now here I am in med school, and I am loving it. And just a quick, most of you can probably assume the reasons why I'm in medical school, but to be succinct, I really love the way that medicine gives opportunities to serve and work with people on a daily basis. And for me, that's always been in the context of chronic care. So I find it very interesting when people are drawn to acute care settings because they want to be able to fix patients and to be able to impact and serve. But from my own experience, have always found that the sort of day-to-day of chronic care is where, like, my physician has been a huge, huge part of my life. And I see him 6 months. As a kid, I saw him 6 months, twice a year, and he had tons of patients. So I assume he was a much bigger figure to me than I was to him. And I think that's something to keep in mind. So just to brush over some of my experiences in underserved care, I am only a third-year medical student. The first 2 rotations that I've done in Portland have been at federally qualified health centers. The NARA is Native American Rehabilitation Association, so I got an awesome opportunity to work with the Native population in Portland, and I really loved it. And right now I'm at another federally qualified health center, Richmond Family Medicine, doing some kind of similar stuff. But all this is to say I've had a breadth of experience working with these populations, and so I've had a decent amount of time to sort of ruminate and extrapolate my own patient experience to these populations. So this is something that almost goes without saying anymore. Frankly, I didn't even pull the literature, but this is what we see a lot of in underserved populations. And the trend here is that these are things that patients deal with really in the day-to-day. And a lot of physicians will talk about how they don't have enough time to counsel their patients and all these issues, and how there's a lot of movement towards improving preventive care for these populations because it can really mitigate or even prevent some of these illnesses. And I think the point I really want to make is that the fact that I have diabetes and the fact that I have a chronic illness, I think, is a particularly useful lens to look through when working with these populations, because there's a lot of translatable components. So when I was getting ready to prepare this talk, I started asking some of my colleagues and my peers and my preceptors, what is it that's so unappealing to people who don't want to work with underserved populations? Why isn't it that everybody is excited about it? And pretty much everybody said the same thing, which really surprised me. But to distill it down, people, physicians, students, providers are exhausted and say people don't want to help themselves. It's frustrating to try and serve community of people who don't want to help themselves. And I found that pretty interesting because I don't think that's true at all. I think that's exactly what people are trying to do. I think that's the human condition, is trying to help yourself. And I'm going to talk a little bit about the discrepancy there between why we think patients are so frustrating because they don't want to help themselves, when really, we're moving into my take-home points. My main take-home point is that really people are rational, and context is everything. And to give an example, my very first type 1 diabetic patient was at a free clinic, and obviously this was very memorable to me. She was a 51-year-old woman, and she wasn't taking her insulin. And it was extremely frustrating to the providers there because they didn't have a relationship with this woman yet. The providers there were awesome and no complaints, but they tended to rotate because they were there as volunteers. And so this woman came in, had a half-an-hour visit, and really was just like another diabetic patient, and another diabetic patient, no less, whose A1C was high, who wasn't taking her insulin. And so it was really interesting to go in and sit down with her and just ask the question, what's the hardest thing for you? And why aren't you taking your insulin? And it ended up coming out that she was having early morning lows consistently enough that she made the decision that it was an improvement in her quality of life. This wasn't precisely how she articulated it, but it was, to her, an improvement in her quality of life to not take insulin, because she really wasn't having 300 blood sugars. Even without insulin, she was still sitting at 200. But she wasn't having those morning lows, which, like I mentioned earlier, are absolutely terrifying, even traumatizing. I hear physicians kind of snicker about diabetic patients who will carb a load before they go to bed, as if that's something that's totally insane. But if you've ever actually experienced a low blood sugar, then that's the most rational thing in the world. It's actually just a conflict between staying alive in the moment, I guess, and the sort of long-term effects that doctors are trained to think about. So I guess in working with chronic patients, what I find so creative and wonderful is that every patient's brain is different, every patient's circumstance is different, and their behavior on some level is rational, but it becomes a puzzle to understand the context in which their behavior is rational. A lot of times they're just playing by a different set of rules than we are, and it's kind of a neat thing to be able to create a connection with your patients and sort of elucidate what exactly those rules are. And is it an issue of patient education? Is it an issue of anything that you can mediate as their provider? Another thing that kind of has frustrated some of the providers I'm working with, or whom they have mentioned in their peers who didn't choose to be working with underserved populations, but I just sort of want to give credence to the fact that if you look for emotional intelligence across socioeconomic status, you will find it. If you look for intelligence across socioeconomic status, you will find it. The same thing in your patients. That health literacy is something that is a luxury of being educated as a physician. And for all intents and purposes, I've spent 2 years studying the language of medicine in books. And third year and fourth year, now I'm sort of in my language immersion program before I become a resident and actually learn how to care for patients. But it's something we invest a lot of time in being able to do. And it is a far cry from a patient's ability to care for themselves if they don't understand communication in the office. So maybe a little bit soapboxy, but I had to throw it out there. And the last thing, I can't give a patient-centered talk without mentioning the need for respecting vulnerability, simply because we as providers can't do our job without patients being vulnerable. And part of that vulnerability is has to do with the human connection you create with your patients. And it's something that's so cool to see with chronic patients in particular, because you have that sort of longevity with your relationship with them. It's not an acute issue where you get to stitch them up, fix them, send them home, which, you know, I'm sort of biased, obviously, in my obsession with chronic illness. But at the end of the day, it is about respecting vulnerability. And I think I'm finishing extremely early because I was talking very fast. Does anybody have any questions? Jenna? I cannot actually hear anyone. Jenna?
Oh, hello. Sorry, everyone.
Oh, hello. Sorry, everyone.
So I unmuted everybody else but forgot to unmute myself. So what I was saying is that I was unmuting everybody so that they could ask questions. So if anybody would like to ask a question, please go for it. So we have a question from Stanley Daniel coming through the chat. He says, thanks for your talk, and can you elaborate a bit more between health literacy and emotional intelligence?
Yes, actually. So obviously, I guess what I meant when I used the term health literacy, I was talking about sort of broadly like the ability to understand medical language, which even the most educated people cannot do sometimes. I'm still working on that, actually. But emotional intelligence has to do with, I think, recognizing your own and reflecting on your own strengths, knowing what your weaknesses are, and being able to explore those things with a patient and have an emotionally intelligent discussion with them about their health is something that has nothing to do with speaking in medical jargon. And it's something that I think is much more powerful when you're sitting face-to-face with a patient. And I just think that sometimes vocabulary gets in the way of that sort of discussion of the very basics, like what resilience looks like for that patient, what their strengths are, what their weaknesses are. Well, I really like to ask the question of any chronic patient, so what is it that you struggle with the most? Just that one question, just pick the thing that's the hardest for them. Because there's always something. I don't know if that answers your question.
Well, it sounded like a great answer to me. Does anybody else have any questions for Heather? If not, I can ask a question as well. So Heather, I was just wondering, listening to you talking, it seems like you've really been able to use your own experience as a patient to relate with patients that you're seeing now as a third-year medical student. So do you have any suggestions of what people can do who have not sort of had that own experience going through the health system as a patient? Are there any things that you suggest that people can do to really relate to their patients?
Yeah, so I actually think I pull as much from my creative writing background when I'm relating to patients as I do from my health history. I think that it's useful to find a framework that works for you. So for me, when I sit down in front of a patient, I actually think about character development. Like I actually think about the questions of what makes this person who they are, what they do, why they're saying the things they're saying, what emotions are present. Like it's all very much character, sort of in a formulaic way. It's a character building exercise, sort of just understanding that. And for me, that really structures my framework. And anyone who's an avid writer or fiction reader could do the same thing, but I'm sure that there are a number of other frameworks that people have. I mean, it's really just about making yourself curious about why people are the people they are. And however you find you can do that, it has nothing to do with if you've had that experience or not. It has everything to do with the fact that you want to know it all.
Sure. Are there any other questions? I guess my other question for people who are on the line now or going to watch the webinar later, could you tell us a little bit more about what the American Resident Project is for people who don't already know?
Yeah, I'm actually glad you asked. I didn't want to spend all of my talk, but it's a pretty cool project. It's sponsored by Sinkwell Point, and essentially, I'm not sure how old it is, but essentially they decided that, the committee decided that they wanted to hear what physician leaders were thinking, what we were saying, kind of throughout the levels of our education, and that way they could know where healthcare is headed. It's kind of just an open discussion. I write monthly blogs. There's a lot of leadership opportunities, but it's sort of a monthly discussion about what I guess I sort of represent all third-year medical students are experiencing, what I'm seeing, the direction of healthcare, how it's going, how I'm understanding my patient experiences, and it makes it a venue for discussion, I guess, among healthcare thought leaders. Does that make sense?
It does. Sounds awesome. Any other questions for Heather from the live audience? I'm not seeing any now. Do you have any final words of wisdom for us, Heather?
I don't have any final words of wisdom. I would have really loved to have heard from anybody who was listening if they had any experiences that sort of resonated with what I said today, but that's okay if no one would like to share. Thanks, Jenna.
Well, we can probe for that a bit in a minute. Is there an email address or anything that you would like to provide for any people who would like to get in touch with you or ask you a question after viewing the recording?
Absolutely. So my medical school email address is alva, A-L-V-A, @ohsu.edu.
Sounds awesome. We will post that up on the website if it's okay with you, along with the recording.
Yep, that's great.
So thanks so much, Heather. We really appreciate you talking for National Primary Care Week. Thanks to everybody who was able to join us live and to everybody who's going to view the recording. Thanks so much.
Thank you.